Welcome to Noon Wednesday. I'm Marissa Wojcik, multimedia journalist with Here and Now on PBS Wisconsin. Today is February 17. Scientists have been genetically sequencing coronavirus test samples to better understand how the virus is moving through communities and to detect emerging variants. Dr. Porrick Kenny, who has sequenced 1,400 samples at a Gundersen Health System lab in La Crosse, joins us now to discuss how these samples can teach us about the novel coronavirus. And Dr. Kenny, thank you so much for joining us. Your specialty is cancer genome sequencing as the director of a team at the Gundersen Medical Foundation. When did you start sequencing the novel coronavirus?
So we had our first case of the coronavirus here in La Crosse on March 18th of last year, and we had sequenced that first viral strain within a week. So very early in the pandemic, we realized that the information we could gain from sequencing was likely to be able to add significant value to simply knowing from diagnostic testing who was positive or negative. So we were very early adopters of this technology here in La Crosse, and we became the 15th lab in the United States to submit genomic sequence on COVID-19 at that time.
Did you understand how important that process was going to be when you initially set down that path?
Well, we understood that the virus had a very large impact, clearly in China, all across Europe, and even, by March in the United States in cities like New York City and Seattle. So we knew that if there was anything that could be done to try to mitigate its impact here in our region, on our healthcare organization, on our staff, and on our patients, that we should probably make an effort to do that. So that was the primary reason that we set off to sequence the virus. And we did not realize at that stage that we would end up sequencing more than 1,400 samples and be still going, this far along.
And backing up one step, so genetic sequencing isn't something new, at least to the scientific community. Can you help us understand what exactly does genetic sequencing mean?
Sure. All organisms, humans, plants, cows, butterflies, and viruses have a genome. It's basically the instruction manual that provides all the instructions how to make one of these organisms. And viruses like COVID-19 are no different. The COVID-19 virus has an RNA genome, but it's basically a long list, a string of letters, A's and C's and G's and T's, 29,903 of them. And that contains all of the information that the virus needs in order to make copies of itself and do, all of the infection process to the point that it can then move on and infect somebody else. So when the virus infects somebody, it needs to make many of these copies of itself. And by taking samples from patients during the infection process, we can isolate that genetic material and figure out end to end what the sequence of that virus is.
And as you are sequencing the virus, you're looking at what it's made of and how those different letters are patterned. As the virus makes copies of itself, there are little differences, and that is how you are able to track the virus. Can you help explain that a little bit better?
Sure. So when the virus makes a copy of itself, it usually does an exceptionally good job of doing that, but occasionally it's going to make a mistake. So you can think of that like a spelling mistake in the genome. So one of those letters is not what it was originally. The thing about the virus is when that virus then goes on and infects somebody else and launches into a chain of infections, all subsequent infections caused by that virus have that particular spelling mistake at that particular place in the genome. So by tracking the emergence and the spread of these spelling mistakes in the virus, that allows us to track and understand which people in the population likely share common sources of infection. And that helps us understand, things in much more detail about how the virus spreads within populations than the information you can simply get by contact tracing. So it's a useful adjunct to contact tracing and all of the other kinds of mitigation strategies that people have been thinking about.
So you can see where these differences occur, and you can see where the differences travel. But your particular lab is unique in some respects because of your partnership with the Gundersen Health System. And so you can track it even more precisely. Can you explain that connection?
Sure. So for people who don't know, Gundersen Health System is an integrated healthcare system that provides care in 21 counties in southwestern Wisconsin, northeastern Iowa, and southeastern Minnesota. And one of the advantages that we had at the start of the pandemic was all of our COVID-19 testing was being done centrally in the lab just down the corridor from my laboratory. So we were able to access a large number of specimens from across this area. We had approval from our institutional review board here at Gundersen as a research project to get access to the medical records of all of the patients who had COVID-19 testing done for, extracting information relevant to their COVID-19, symptom onset and things like that. So we were able to pretty efficiently and quickly build a map of viral transmissions across our region that was well annotated with a lot of the demographic information on these patients, their age, gender, and all sorts of comorbidities and other related issues.
And so with that information, you were able to track where the virus was traveling within the community surrounding you. Last fall, you wrote a study following the virus from students coming back to campus and connecting that virus to showing up in nursing homes in the area. There was some immediate criticism of that study, drawing premature conclusions. Months later, now, do you stand by those findings?
Yeah, we're still pretty confident that the findings we described back in October, are, quite accurate. So we had about 2,000 cases of coronavirus in La Crosse County over the month of September, the majority of which were attributable to younger individuals in the college age demographic. So we were sequencing, very, very aggressively at that time. So we had a very, very good knowledge of the types of substrains that were circulating in that student age demographic, in the sort of super spreader events and parties that were going on in La Crosse at that time. And then within 2 or 3 weeks, we started sequencing cases from patients in our nursing homes in town, and they were sharing identical virus essentially with the viruses that had been circulated in among the student population. So for us, I think that's a really good example of how when the virus is allowed to get out of control in one setting, we're all very closely connected. College campuses like meatpacking plants and all kinds of other places don't have high walls around them. People who go there interact with others in the community. In La Crosse in particular, we've got a very health professions focus in many of our third level institutions. So a lot of the students actually work in nursing homes as CNAs and things like that as part of gaining the experience that they need for their own professional development. So there are very clear lines and avenues whereby the virus could be transmitted between one population that's generally pretty low risk and another population that in this case was obviously very, very high risk.
Are there lessons that we can learn from what you were concluding from that study?
Yeah, I think college administrators and chancellors and presidents had a large number of concerns over the summer of last year. They were concerned about enrollment, they were concerned about safety for their faculty, they were concerned about spread among the students. But I don't think, and it's certainly not limited to Wisconsin, I think across the country, there was not a very broad appreciation of the impact that some of these college reopening decisions could have and likely would have on the surrounding communities. So I think, going forward, it's very important to look at these types of situations with dorm living and off-campus housing as potential sources of spread of infectious pandemic diseases, and to recognize that this is a true cost and a burden that's placed on the communities and should be recognized by all of the people involved in making those decisions.
Now, does that population, the college student population, and students going back to campus in that way, does that differ from K-12 students going back into the classroom, as many schools across the state are heading back into classrooms? In Madison, which was considered to be kind of the bellwether of students staying out of classrooms or going back to school, they will be returning. Is that is that happening too soon, or can we look at those populations, college students, K-12 students? Do we need to look at those differently?
Yeah, I think we need to look at them very differently. And I think even within K-12, we probably need to break out high school students from elementary school and middle school students. So I think all of these populations have their own risks and vulnerabilities. With the college age population, I think the biggest risk is all of the socializing, the beer pong and all of that, things that are not so popular among elementary age students. So I think we definitely need to assess risk for these populations very, very differently. I think the little kids, for reasons of biology, with their interaction with the coronavirus, probably pose the least risk. Once kids get up to middle school, high school age, their anatomy and physiology is much more similar to that of adults. So they should probably be regarded as a separate risk group compared to younger elementary age students. And college students are at a higher risk level again, both for themselves and for the surrounding population.
So as you were describing earlier, these copies create slight differences in the virus, and therefore they create mutations. And as those mutations happen, the virus changes little by little. And as many people know now, there is one variant that is causing some concern. It originated from the United Kingdom. It is known as B.1.1.7, and it is considered to be more contagious. It's now been detected in Eau Claire, Waukesha, and now Milwaukee. First, I want to ask, is genetic sequencing the only way to detect a variant like this?
Genetic sequencing is the best way to detect a variant like this. We and others are working on some technologies and diagnostic approaches that should provide more rapid turnaround than testing the entire genome, because a variant like this has a hallmark of a couple of different spelling mistakes that we can test for by themselves without needing to work out the full 29,903 letters. But for now, gold standard really is genetic testing, so full length genetic sequencing.
And now that we know it's in communities in Wisconsin, different parts of the state, should we assume that it is more prevalent than even what has been detected so far?
Absolutely. So I think Wisconsin is one of the leaders across the United States in states that are doing genetic sequencing. If you look at the raw numbers, we're ranked, I believe, 7th across the country, but that's competing against states like Florida and California that have much larger populations. So if you look at the rate of sequencing per head, we're in 2nd place in the country. So Wisconsin is doing very well at this kind of surveillance, but we're still sequencing in the very low single digits. So if you see, if we were sequencing, let's say 2% of cases and we know of the existence of 4, it's a pretty safe bet that there's, substantially more than 4 cases out there. And from what we've seen with the introduction of this virus to Florida and California, we see that once it gets a foothold, it can take off very, very efficiently. So in Florida and California, this B.1.1.7 is now comprising up to maybe 8 to 10% of cases that are being sequenced, and that's doubling every 10 days. So it clearly is a more transmissible substrain, and I think it's entirely reasonable to believe that there's a lot more of it in Wisconsin than is currently apparent from the sequencing data.
And so as we are trying to understand how these different variants behave, how they move, and what they do to a human once they're inside of a human, are we able to understand if the B.1.1.7 variant, for example, is more dangerous or less dangerous than the original novel coronavirus that we have seen for the last year?
So that's a great question. I'll break it out and consider both of those separately. So there's whether this is still, whether it's actually more dangerous or not on an individual level is still the topic of a lot of discussion. There's some evidence that it may be at least moderately more severe. The biggest risk is down to its level of transmissibility. So there's a whole lot more of this particular strain. This strain has more potential for spread. So even if it is just as severe or no more severe than the previous strains of the coronavirus, the fact that it can infect more people is significantly is going to make it more dangerous, because the more people you infect, the more people are going to get significantly ill.
Some scientists have reported in media that generally when a virus mutates and spreads and evolves throughout a population, it tends to become more contagious but less dangerous. Are you saying that we just can't draw that conclusion yet?
I don't think we've got solid information one way or the other for that. I mean, this is just one substrain. There's a lot of other substrains that have emerged. It's certainly possible that some of these may be less hazardous, but there are certainly some on our radar now that are of significant concern. So I think all of the things we've been doing so far with regard to masking and distancing remain important.
I want to ask you about your work with genetically sequencing the virus and how it connects to vaccines that are being made. Was the work genetically sequencing the virus, did that help producing the vaccine?
So I'll give great credit to the Chinese initially, because they were the first to bring out a sequence of this virus very, very early in the pandemic, back in January. And that sequence formed the basis of all of the vaccine design that took place through the spring and summer of last year. The sequencing we're doing now and that is being done across the world is really highlighting some of the potential variants that are emerging that might create risk that there may be a variant that may escape the effects of the vaccine. And I think that going forward is very important to look at, because it will point towards how we can redesign these vaccines if necessary with a booster shot or something like that. One of the variants that has emerged pretty recently in South Africa, called B1351, is probably the one right now where we have most concern about a potential lack of efficacy of several of the vaccines that are being used at the moment.
To retool a vaccine and to use the information that we have about the variants, does that require as much work as it took to create the original COVID-19 vaccine that is being distributed now?
No, that's a great question. So these vaccines are essentially, at least the RNA vaccines, the ones from Pfizer and Moderna, are essentially synthesized in the lab. There's a machine that takes in the genetic code that it's supposed to produce, and it produces that. So it's really a couple of keystrokes is probably all that is necessary to retool a vaccine to encompass protection against some of these emerging variants. What's a little bit unclear right now, but is actively being worked on, is how much trials are going to need to be done in a situation like that. Clearly, for flu, we have new flu shots every year without having large trials in the population, because we've got a pretty good understanding of how flu vaccines behave. So the trials so far of the COVID-19 vaccines have included about 160,000 people across the world. I certainly don't believe it's going to be necessary to have another trial of 30 or so thousand people to test a new vaccine that has maybe one very, very minor difference. So we, I think, as a community, should be hopeful that the FDA and others will see a fairly clear path through to allowing these vaccines, booster shots, to be used more broadly and to do that efficiently if necessary.
COVID-19 infection rates, both in Wisconsin and across the United States, have been trending downward, at least since about January. Are you able to attribute this to any one thing in particular? And should we start relaxing some things like our capacity orders and other health guidelines that were put in place to mitigate the spread of the virus?
So it's been great to see the downtrend in numbers of coronavirus cases that we've had here in Wisconsin these past several weeks. But I think it's important to think about where they're coming down from. I mean, we had a terrible time on the run into Thanksgiving. We had another bump after Christmas, but now our levels are similar to what they were in the early fall. And, none of us were happy about, that level of COVID-19 infection in our community at that stage. And while it's relieving that things are a little bit better than they were, I think we should still have quite a bit of concern about the level of disease we have in the community right now. I think the rollout of vaccine is probably going to help with that. But I think we still have a large fraction of our community that's vulnerable to COVID-19 infection, and significant relaxation of the protective measures that we have, done pretty well on in many cases in Wisconsin will place us at risk of seeing another upsurge.
And speaking of another upsurge, could the variant cause another upsurge? Could someone who has already been infected with the coronavirus, the novel coronavirus, perhaps last year, are they at risk for spreading a new variant?
Yeah, that's definitely a concern that we have. So among the emerging variants, that one that I mentioned that was first detected in South Africa, the B1351, is probably the most concerning one about the potential for reinfection. So in the trial in South Africa for a vaccine run by Novavax, they had several infections in both arms of the trial, the vaccine arm and the placebo arm, that affected people who had prior infection with the coronavirus. There's another strain that was detected in Brazil initially, in Manaus, in the Amazon region, called P1. And that region of Brazil was hit very, very hard by COVID-19 back in the summer. But yet in October, November, they were hit hard again by a second surge with reports at least coming out of reinfections attributable to this P1 strain, which was detected a couple of weeks ago in Minneapolis. So there are certainly some concerns out there right now about the potentials for reinfection with some of these emerging substrains. And while it's been good to see that most of the people who've had COVID-19 so far do seem to have an enduring protection that's lasting at least this long, and none of us know how long more it's going to last without vaccination, there is certainly a concern, particularly with some of these immune escape variants, that reinfections may become a problem.
So we're not out of the woods quite yet. The United States generally lags behind other countries in this endeavor of genome sequencing for the coronavirus. Wisconsin is ahead of the pack in terms of other states. Why is that?
I think Wisconsin can take great pride in how well we're doing compared to some of the states and regions, multi-state regions across the country, which have really been black holes for sequencing, where we really don't know what's going on. I think Wisconsin got quite lucky. There was a couple of folks in Madison, Professor Dave O'Connor and Professor Tom Friedrich, that were, really good virologists and had an interest in sequencing. There was me over here in La Crosse that had, a large interest in sequencing, but didn't really know anything about infectious disease. But I think there was a collection of people who had the equipment and the expertise, and also the realization that something like this was going to be important. It was at a time when there was a real vacuum in leadership in our country from the CDC and others about, providing guidance about how something like this could be done. So really, it was a grassroots effort, and it's, a grassroots effort where people are collaborating across the country in organizations like ours to produce this data in the absence of, at least for a long time, a significant amount of leadership and guidance from overhead. So I think we've been very lucky in Wisconsin that we've got good support for research and support for the people like us who've been doing this type of sequencing.
Earlier this month, Senator Tammy Baldwin introduced legislation to expand this type of work. Do you see that as being necessary? Even as the vaccine is being rolled out, we're seeing these cases trend downward. Do you think we still need to ramp this up? And have you worked with the CDC at all about this effort?
Not about this particular effort, but the CDC, the Office of Advanced Molecular Diagnostics, since the early summer of last year, has had a coordinating activity called SPHERES, a consortium of investigators like myself and others from across the country who are involved at any level in this kind of sequencing. And that hasn't provided really any financial support, but has been an excellent sort of organizational and coordinating influence on all of these efforts. It's great now to see from Senator Baldwin and others a stronger push at the federal level towards providing actual support for this genetic sequencing. And I think, especially with the emergence of these variants, it's going to be important for, at least, many, many more months to track their emergence and understand how we may need to retool these vaccines if necessary.
For the folks at home, how should they incorporate this information into their daily lives?
I think the messages for now are the same as the messages we've had, since the start of the pandemic. Try to limit your bubbles, limit your discretionary contact, wash your hands, do your social distancing. Now that we've got the vaccines, try to get in that line for vaccine. I think the rollout of the vaccine is slower than many of us would like. But at the same time, it's been great to see the eagerness from very, very large sections of our population to get vaccinated. So that's going to happen over the coming months. And I think as the vaccine penetrates more deeply into the community, we all will be feeling a little bit more protected. But in the meantime, especially with schools going back, like we've already discussed, now is the time to double down on all of the preventive efforts that we've been, so well trained on over the past many months.
I think many were disappointed to learn about these variants when we were already feeling so much COVID fatigue. Do you, in your work, see a light at the end of the tunnel?
Oh, there is absolutely a light at the end of the tunnel. I mean, I think none of us, back March, April, May of last year had a hope that we would have even one vaccine with much more than 50 or 60% efficacy. And, now we have a range of vaccines with up to 90% efficacy, produced in less than a year, which I think is a really, really remarkable technological, organizational, and, medical achievement. The variants are certainly a concern, but like we've discussed, there's a very, very clear path within that vaccine technology to retooling for booster shots. So there is absolutely a light at the end of the tunnel, and hopefully we'll get there soon.
Dr. Pádraig Kenny, thank you very much for joining us today. For more from Here and Now and PBS Wisconsin, you can visit pbswisconsin.org. And thank you so much for joining us on Noon Wednesday.